So good afternoon to all present here today. I would like to express my thanks for this opportunity and the stage. So today I'm speaking on reducing treatment burden in retinal vein occlusion, applying acquired knowledge of aqueous biomarker profile. So briefly on retinal vein occlusion, the primary event is the obstruction of retinal veins, usually by a thrombus formation. Post-obstruction, there is raised venous pressure, hypoxia, increased in capillary permeability that results finally in macular edema. Numerous studies have proven the role of anti-VEGF and steroids for treatment of macular edema in RVO. Aqueous profiling of treatment-naive RVO have confirmed the presence of both inflammatory and angiogenic process, establishing it to be a complex interplay of both processes. In our study, we did a blanket suppression of both by giving combined anti-VEGF and steroids. We also studied the aqueous humor profile of all the patients. The results of our analyses showed that patients receiving combination were more likely to achieve the target BCVA earlier compared with the patients receiving anti-VEGF alone. The combination therapy offers a greater reduction of CMT, and the greatest advantage of combination therapy is that the number of injections is reduced and fluid-free interval is much longer in combined. That's not all. Along with noticing significant reduction of CFT, the likes of which won't be seen with the monotherapy alone, our cases also showed us a variable soluble biomarker profile, and that's where the limitation of a study also lies in. What we did was a blanket suppression of both processes without understanding the dominant driving process behind the edema. It was like giving empirical antibiotic therapy for all the infections. But what it helped us? It did help us in understanding the disease better and how in the long run this would pave the way for more tailored approach. Like for this case example, where the driving process is inflammation demonstrated by raised IL-6 level, giving anti-VEGF in this case scenario would not have been fruitful. What we have discussed here is just one of the applications of biomarker profiling to the clinics. In future, it opens up the way to multiple eventualities. It offers the opportunity to stratify patients based on their molecular profiles, where they can be categorized into subgroups with varying disease severity and progression rates. By tracking changes in biomarker levels over time, clinicians can identify early signs of treatment resistance and disease recurrence, enabling timely interventions. So with deeper understanding of molecular characteristics of disease, we can develop personalized treatment plans that also takes into account individual variations in biomarker. So this bespoke approach optimizes treatment outcomes by selecting the most effective interventions for each patient while minimizing adverse outcomes and reducing treatment burden. There is potential to reduce overall healthcare costs associated with the disease by optimizing treatment efficacy and minimizing unnecessary interventions. So in summary, aqueous-soluble biomarker profiling transforms the treatment paradigm by enabling a more bespoke approach to individual molecular characteristic of each patient. So what this presentation shows you about applying the labs to the clinics is just the tip. There is this whole iceberg of multitudes of possibilities still waiting to be explored. Thank you.
So what are your proposed clinical applicabilities of this methodology?
So, ma'am, as we have seen, first of all, whether when we are collecting the aqueous sample, it helps us to determine whether the edema was inflammation-driven or angiogenic process-driven. In that way, we can decide whether we want to go ahead with anti-VEGF or steroid. And usually what we have seen if the primary macular edema is because of inflammation, the next time when the patient again gets edema, it would be mostly because of inflammatory markers itself. So next time we can plan to go ahead with steroids rather than going for anti-VEGF. This is the one thing, and now we have come up that case example we've seen where IL-6 was high. We have seen case examples where ICAM1 was high, and all these things. So we are in the process of developing particular, like specific ICAM inhibitor, LFA1 antagonist and everything, which will particularly go and suppress that one thing, and that would actually address the exact biomarker responsible for the whole problem.
Have you tried correlating it with OCT or OCTA?
Oh, yes, ma'am, we are doing it, although where, what OCT features, what OCT biomarkers correlating with what aqueous biomarkers, if this is high, if we are seeing that and that, so all these correlations are going on simultaneously.